All right. Well, this first and foremost, thank you for having me. I always welcome the opportunity to talk about BFR. I think it's not if, it's when, and that just means that um, as of the last couple years, BFR has been exploding in popularity. Not even because of the evidence that we have supporting its use in promoting positive musculoskeletal benefits, but it's really driven by physicians and physicians that are seeing the benefits of BFR, not because they give a shit about what's published in physical therapy journals. I've literally been told that twice by two separate surgeons. They care about what their colleagues are saying about BFR. And recently, in the past couple of years, there's been a large increase in physician-read journals on the benefits of BFR and physicians espousing them, like Dr. Robert LaPrade, Dr. Frank Noyes. Those are two prominent orthopedic surgeons that have said in the discussion sections for their papers that they've published on BFR that they use BFR 2 to 3 weeks post-op, regardless of the knee conditions that they've had, the patients that have had. So it's really not driven by physical therapists. It's driven by physicians, and physicians now are seeing the benefits of BFR, and they are writing scripts to say, hey, you need to do BFR as part of your post-surgical or post-injury plan of care. And that's really why BFR is growing. So it's funny because when I was given this, I've been teaching this, I'm teaching BFR for since 2019. And it's amazing what those last 5.5 years have gotten to the popularity of BFR. So this presentation is really meant to be a general deck. It's not going to go too heavy into various clinical populations because this is a 1 hour presentation, but it should give a nice overview for people that that again will foster questions. So I'll try to leave um, you know, 10 minutes of questions at the end. So hopefully around 8:50 or whatever, I have my presenter view so I can at least see the timer. So that's good. For me, I've been interested in BFR for a number of years. It's actually going on over a decade now that I've been aware of BFR. I've used it in various forms, and I'm very fortunate that I am heavily involved in research. I've published at the end of this year, it's going to be over 60 publications in the space. My main interests are on the safe adoption of blood flow restriction and the device features. So not every BFR cuff is created equal, and I'm really spearheading the study of those potential differences in the cuffs. At the end of the day, BFR is a tool, and it's a tool that, when used effectively, can be extremely helpful for your patients. But I am also the BFR guy that will tell you not to do BFR. If you have other things that you can do, they're heavy lifting is more efficient and well studied. So, it really is just context dependent. So I am, in terms of financial disclosures, I am the founder and owner of the BFR Pros. I have an education company, so I am purely interested in the safe application and implementation of blood flow restriction. I don't have any financial relationships with any cuff companies, although they have tried. I don't want my research to be sacrificed or painted in any way, shape, or form regarding that. So that's that. So the agenda really is this. We are just going to talk about the state of the science, how we can make sense of blood flow restriction. So with that being said, hopefully you can hear this. This is an excellent segment on blood flow restriction for those that have not had any real history of or knowledge of BFR. This is a great clip that was aired in 2017 regarding Dwight Howard's use of blood flow restriction in the NBA in season to help with his knee injury. So just let me know if you can hear this.
On a night in early March, after a Rockets win, Center Dwight Howard addresses media.
Okay.
But before he leaves, Howard has one last commitment. a unique training session with Rockets physical therapist Jason Biles. It's part of a routine designed to keep Howard on the court and off the injury report.
It's good because when I'm doing the exercise, it takes a lot of the pressure off my joints. So I'm getting the same workout in, but the load is not as heavy on my knees, which is very important, especially when you get up in age.
Last season, Howard missed 41 games, many as the result of a cartilage injury in his right knee.
I had some stuff in my knee and it just kept bothering me. And every time I went to jump and move, I was like, man, I just feel this pain in my knee.
Howard really limping as he comes up the floor.
I'm always jumping, always in the air, always coming down and putting a lot of force, on my feet and my knees and my back.
Rejected out of bounds.
We realized that we needed to have a plan for Dwight.
Dr. Walt Lowe, head team physician of the Houston Rockets and the Houston Texans, sees cartilage injuries as particularly threatening for NBA players.
These guys play 82 real games a year. The average guy runs about 5 miles every basketball game on a fairly hard surface.
Lowe says not all injuries require surgery, including Howard's, but there are concerns about lingering weakness of the muscles responsible for protecting the knee.
They load their knees, they load their spines, they load their body in just an exponential way compared to a lot of the other sports. And so that's where the BFRs come in to use with Dwight.
BFR, or blood flow restriction training, utilizes a specialized tourniquet cuff wrapped around the upper portion of the arm or leg. The cuff is inflated to a pressure that reduces blood flowing into the limb by approximately 80% and restricts all of the blood from flowing out.
So his max pressure is 202. We take 80%, and that's how this 161 number comes up. So that's the number, the pressure that we'll exercise at.
Are you getting the burn?
I am feeling the burn. Yes, I am.
And it only gets worse because we have 2 more sets of 15 after this.
Yeah, after this, I want to go to sleep. Oh, boy.
The decreased blood flow results in less oxygen to the limb. Exercising the muscles in this low oxygen state allows the athlete to use very light resistance, yet achieve strength gains similar to exercising under heavy loads or high intensity.
So I think that was a really good clip because you get to see BFR in action, hear about the rationale, and see it, in use with a high-level athlete. Now, why blood flow restriction? Well, the goal here is to reproduce a high-intensity training stimulus with lighter loads or lesser intensities. And if you look at the image on the right, this is, the patient lifting moderate to heavy weights. You see the dumbbell. And obviously, as physical therapists, as people that are hopefully bridging athletes and other fitness enthusiasts that might be injured or following surgery back to their normal lifting routines, we should be striving to get them there. But when they're early in the stages of their rehabilitation in, following surgeries, injury, whatever, then they're going to obviously be compromised in their ability to accept load throughout that joint or muscle. And that's where BFR can come in, because it can reproduce that high intensity training stimulus without the external mechanical load. And research has been shown to exhibit benefits in a number of different populations: heart failure patients, post-surgery, which should be familiar to us as physical therapists, HIV/AIDS patients, neurological patients, kidney disease, and those undergoing hemodialysis, cardiopulmonary surgery patients, old to very old people, severe hemophiliac patients. And what's interesting to me regarding the safety aspect of blood flow restriction is that at CSM, Combined Sections meeting, 3 years ago now, there was a group in University of Miami that was showing footage of individuals that were mechanically ventilated in the intensive care unit and cycling with blood flow restriction. And that is because atrophy happens very, very quickly. And we want to be able to try to combat that and the negative sequelae that happen following periods of disuse, immobilization, or restricted weight bearing, etc. So this is these populations I say here just to show benefit is because they all exhibit the same impairments that the orthopedic patients are going to be experiencing, which are reductions in muscle mass, reductions in muscle strength, reductions in aerobic capacity, their ability to perform ADLs, all of which BFR has been shown to be effective at treating or at least helping contribute to improvements in those characteristics. So how do we progress BFR? Well, first, the first and foremost, there is the passive application of BFR alone without active muscle contraction. That is ischemic pre and post conditioning and self-swelling. I don't really spend a lot of time on that because I'm really of a firm believer that tension, or mechanical tension, is really going to be something that we need to optimize as early as possible in the post-surgical or post-injury period. So using passive applications in the rehab setting is not really something that we have the time for, because these protocols can take 30 minutes or so, 5 minutes on, 3 to 5 minutes off, repeat 3 to 5 times. Who has time for that? We certainly don't. So it's not something that I think is really important, but is gaining popularity in the recovery sector and in athletics. So that's a whole nother story entirely. And then we have pillar 2, cardiovascular exercise. This is a nice way to get people comfortable with the stimulus of BFR, but not necessarily crush them like pillar 3, resistance exercise. And then we have the last one, which is a return to sport application, which is really for moderate to high intensity aerobic work and BFR, which is a nice and evolving area that might have different philosophies behind the benefits that are the reasons why you would apply it. So for example, you know, in traditional BFR, as we said before, it's low intensity exercise, but aerobic exercise might have a little bit of a different adaptation profile with respect to what we're seeking when we're implementing it in our practice, versus something like resistance exercise, where we can replicate the benefits of high intensity exercise without having to go higher loads. So that is those are kind of like the 4 different applications of BFR. And I focus on muscle. And why do I focus on muscle? Well, because you ever heard the phrase, when there's smoke, there's fire? Well, for us in this context in particular, when we facilitate muscle growth, we can facilitate a host of other positive physiological benefits, such as, you know, in this chart right here, this is for space travel, actually. Luke Hughes, one of my colleagues, we published a couple of papers together now, which is pretty cool because I've looked up to his work back in 2016, 2017 when he was a PhD student, and now we're colleagues and publishing together. Pretty cool. But he is now at the UK version of NASA, and part of his, the prep work in order to get funding for his space BFR stuff was to write a paper on the effects of BFR and what it could do to space travel. So this basically goes through all the different mechanisms, the known mechanisms, and the mechanisms that we think are happening with regards to BFR application, and what the multiple different adaptations and tissue types that it can affect. So as you can see here, you can see aerobic capacity differences, her hypertrophy, strength, tendon, bone. Those are really cool up and coming areas. Again, I hold high amounts of skepticism for tendon and bone adaptation, but we are seeing evidence that BFR can replicate the benefits of higher intensity exercise in that as well, which is pretty cool. And then vascular adaptations. When we increase our muscle mass, guess what? Feeds our muscle mass, vascular tissue. So we start to see all of these different benefits. And what does muscle do? Well, it combats inflammation. And so even though we look at it like an aesthetic tissue, it is very much a systemic organ that can help regulate inflammation, which is really important in an age where everyone is rampantly inflamed in some way, shape, or form. So I always think it's important to appreciate the context. Whenever we're trying to implement something in our practice, it's important to have contextual factors that inform whether or not or the scene, basically, whether, and taking a cue of what the weather is, et cetera, et cetera. But in our case, as physical therapists, what we see is skeletal muscle atrophy. But that is merely a symptom of underlying, mostly local, but as I mentioned before, somewhat systemic impact on the ability of our tissues to upregulate and become anabolic, right? And there's the resistance to that to the anabolic pathways being heightened is called anabolic resistance. And anabolic resistance makes it very hard to put on muscle after you lose it. And it is a process that results from inactivity, lack of weight bearing, could be cancer induced, and there's multiple different pathways to get to a state where your tissues are anabolically resistant. But if you think about it and you look here, when we stop moving, then we start to remove the signals that maintain our vascular tissue, that increases inflammation, insulin resistance, and downregulates our satellite cells, which are the cells that basically direct muscle protein synthesis to happen, and thus we impair our ability to regenerate muscle. All of this is present to me when I look at an atrophied limb. I understand that happens. Now, what are our tools to be able to combat that? Well, we have two different tools. We have the first one, which is well in our wheelhouse, which is exercise. And then we have the second one, which is nutrition. Now, unless you're a nutritionist or dietitian, you can't really talk about personalizing diet plans, but improving protein is going to be really important. Why? Because the balance, or net protein balance, NPB, minus muscle protein synthesis minus or muscle protein breakdown, that equation, if it's positive, then you're in an anabolic state. Why? Because muscle protein synthesis is elevated beyond the muscle protein breakdown, and you're in catabolic state that promotes atrophy if the reverse is true. And so anabolic resistance is, by definition, in a very challenging state to elevate your muscle protein synthesis in your muscle protein synthesis levels. So you can do that with good nutrition and exercise. But if you're not a nutritionist or a dietitian, then there's no point there's no harm in giving nutritional guidelines that emphasize a high protein diet. In fact, the research does support that as you are injured, you need more protein rather than less. So a lot of people just get lazy. They just, use this time to chill out. But in reality, this is the time to really increase your protein intake. Now, I've also referred people that need more tailored guidance, but this is something that is crucial to helping with combating that skeletal muscle atrophy. And then we have exercise, right? Exercise is our bread and butter as physical therapists. So we should be very comfortable with exercise, I hope. But unfortunately, when you look at the evidence, light load exercise requires a ton of repetitions. And so even if you're injured, right, how many times can you lift a 2-pound dumbbell, right? Hundreds of times before you would even get remotely, if at all, fatigued. And so whatever we're doing in the clinic is probably not enough to meaningfully stimulate muscle growth and meaningfully improve muscle strength. But there's good news. When you add blood flow restriction to whatever repetition and set scheme that you're doing in the clinic, you can be assured, pretty much guaranteed, that you're going to improve muscle mass and improve muscle strength. That is one of the most guaranteed things that I can say here is the effect of BFR on improving muscle mass and muscle strength, certainly to an extent beyond what would be experienced with work matched, meaning the same amount of work done exercise in low intensity exercise. So this is something that we need to appreciate and understand, that what we're doing in the clinic is probably not doing enough to combat that anabolic resistance and combat that atrophy from further progressing or getting out of that hole. So then you look at, okay, what about high load exercise? Because we should be trying to get our patients or clients back to high load exercise as soon as possible, because that's going to be the best for the neuromusculoskeletal system. So what the evidence currently does say is that regardless of the load with BFR, it does appear that BFR produces an equal hypertrophic stimulus to high load exercise. That is really cool. But that also mirrors what we understand about normal strength training, in that load doesn't appear to be a huge factor in muscle growth, but it does appear to be a mediating factor in muscle strength. So these are things that we need to put in our back pocket, appreciate, and implement in the clinic with regards to, we want to try to get our patients back to high load exercise as much as possible. But because we're able to give them a high intensity stimulus with light loads that they wouldn't normally be able to get otherwise, we can use BFR as a bridge to get them to that higher load exercise. That is the optimal use of blood flow restriction in rehabilitation, is getting them to higher loads in a situation where they couldn't normally get that stimulus. So here's a 10,000 foot overview of blood flow restriction. We saw that in the video, but what we're getting here is we're using some sort of cuff calibrated by technology, whatever that means. That means Doppler, that means computer, that means embedded, that means manually, with a pulse ox, something like that, that's going to produce a controlled reduction in our blood flow. And we can make it more complicated by adding a machine that will do it for us. Not necessary, but definitely a nice boost if you have access to do that. But after that, then we get this energy imbalance. Why? Because we're cutting off arterial flow to some degree, and we are occluding venous return. So we get this congestion of fluid in the limb, which creates relative hypoxia, because now the gradients between the limb change. And so now it gets harder to be able to extract oxygen when you're not getting the vascular tissue offloading all that fluid, the blood, with the metabolites, etc. You get this energy imbalance, this energy shift from aerobic to anaerobic. And that leads to an earlier onset of fatigue. And this is the same thing that happens under normal resistance exercise. The only thing is it happens much quicker with BFR. Then over time, we start to exercise, we get hypertrophy of the type 1 fibers, we get hypertrophy of the type 2 fibers, which ultimately give us our visible increase in muscle mass and strength. The next question then you should be asking yourself is, okay, so we have to restrict the blood flow to some degree in order to get that a fatigue accumulation. So is there a recommended approach to controlling the amount of blood flow? There is. There's called limb occlusion or arterial occlusion pressure. And what that does is a number of things. Number one, it allows for a subocclusive safe stimulus to occur. So we're not guessing. We assess, we don't guess. Limb occlusion pressure is an assessment that allows us to make sure that we're optimizing the application of BFR there. Number two is that it allows for a within and between subject assessment or comparison. So like we know that if it's a trial and we're using 40% limb occlusion pressure, that person is going to receive 40% limb occlusion pressure throughout the trial. We also know that the perceptual demands are going to be modulated in part by the amount of pressure that's applied. So we can then look and say, all right, a 40% pressure versus 80% pressure. What is the difference in responses, right? Difference purely through the application of more pressure, right? But we're still subocclusive and we're exercising under subocclusive pressures. There's no need to exercise with more pressure. So generally the recommendations are 40 to 80% limb occlusion pressure to promote the efficacious use of blood flow restriction. And then we can also use LOP to compare different trials. So like what is a leg extension exercise performed at 20% of the 1 rep max do in patients that are undergoing hemodialysis versus persons that are recovering from orthopedic surgery, right? Are there similar differences or similarities or differences that it might be noted? Well, because we're controlling the pressure, that's going to be one less variable that we need to worry about in terms of comparisons between groups, right? So it's a way to create that standardization, and it's pretty easy to use in practice. So I mentioned before, BFR just accelerates fatigue. And I think the way that I teach BFR, both in my on-demand courses, I own BFR training and I own bloodflowrestriction.com, believe it or not, which is pretty cool. But all my courses are housed there. What we do is we try to reframe BFR from a magic type thing to firmly entrenched in what we understand about exercise physiology and strength training. So here is a graph from Chris Beardsley that kind of goes through that. In order for us to meaningfully increase muscle mass, we need to recruit the high threshold motor units. The high threshold motor units are the motor units that are predominantly composed of type 2 muscle fibers. Remember, back to exercise phys, a motor unit is a motor nerve and their associated muscle fibers that motor nerve innervates. Now, when you were lifting with light weights, we're not stimulating the type 2 fibers at all, because the type 1 fibers with the aerobic environment, we're able to handle that. It's only until we do enough volume that there is some backflow that happens that we start to accumulate fatigue, that then now we necessitate the recruitment of those high threshold motor units that have the type 2 muscle fibers in them. When we slow down our concentric velocity, meaning that when we're doing a bicep curl, we're trying to bring our arm up from at our side to now in front of us, that speed needs to involuntarily slow in order for us to really maximize the muscular benefits of the exercise. But that only happens with light loads when we're tired. And unfortunately, that when we're using very light loads, that's typical of what's happening in rehab, we tend to need a ton of repetitions to be able to do that. So the likelihood that we're actually experiencing that meaningful stimulus is nil, basically. And so all of this is important. I drew on this ahead of time so we can kind of go through that. Again, I want to hammer home how BFR is not magic. It's firmly entrenched in our understanding of exercise physiology. So if you think back to the force velocity curve, this is the concentric portion or the muscle shortening part of the muscle contraction. We are making an assumption that this is maximal effort. So maximal effort is important because effort is correlated with muscle activation. We need high levels of muscle activation to be able to recruit the high threshold motor units during high load exercise, for example. Why? Because if you look at the y-axis, which is muscle force, which I want you to think of as analogous to mechanical tension, just because when we're trying to overcome a contraction in the concentric phase, we're getting this pulling force. And so we need to overcome that pulling force, and that muscle, the actin-myosin overlap that then creates the shortening of the muscle fiber, that creates muscle force or mechanical tension at the muscle fiber level. So I want you to just think about that as that. And that's why when you look at high load exercise, why it's the gold standard is because we're moving very slowly. That's the x-axis. But the muscle fibers that are recruited are all undergoing high levels of tension. And that gives a nice hypertrophic stimulus. Conversely, when we're lifting with light loads, and I substituted BFR training for light loads, but light loads generally are 30 to 40% of the 1 rep max or less, right? We, unless we're tired, is the only time we're able to create enough muscle force. If you look at this area right here, this is nothing, right? We have a lot of muscle fibers that are active, but they're sharing a lot of the load that goes through. So the force per individual muscle fiber is very low. When that's very low, it's not a hypertrophic stimulus. It's only when we're able to induce fatigue that we're able to creep up to the upper left-hand part of the chart and replicate that high intensity intramuscular environment that will give us that hypertrophic stimulus. So if you understand the force velocity curve, and you can then explain BFR to your patients. It's basically replicating the intramuscular environment of high intensity training. Now, how do we know that? Well, number one, we know that when we apply BFR, it takes about 43% less reps to reach volitional failure compared to the same workload without BFR. And when we normalize it to task failure, meaning we have two two groups exercise to failure. One group does 100 reps, one does 50. Well, at rep 50 in the one group and rep 100 at the other, right? That's failure in both, right? We see similar muscle deoxygenation, muscle activation, and rating of perceived exertion, but in the BFR group, we see higher amounts of muscle discomfort. And that's very common, and that's something that we need to communicate to our patients, because BFR is going to be more uncomfortable than performing the same exercise without BFR, right? It's probably due to a mixture of the heightened metabolic stress along with the mechanical compression of the cuff. And so the cost is the discomfort. And that's where you as a BFR provider or someone that's going to be administering BFR needs to be comfortable with telling your patients that, hey, if you're not experiencing significant amounts of discomfort, you're probably not working hard enough. How do we know that it's basically identical between conditions, though? Is that longitudinal trials that look at BFR versus no BFR show no differences in long-term muscle growth. We get to the same endpoint every single time. It's just we open up time, basically, with the addition of blood flow restriction in our practice. So that's really cool. So this is kind of the summary type figure, which is really just we get to the same endpoint. It just happens a lot quicker. When we think about relevant mechanisms of BFR, I actually just think that BFR largely works, at least in the resistance exercise setting, through mechanical tension. But that doesn't mean that the metabolic stress is meaningless, because the metabolic stress is going to clog up the cross-bridge cycling process, which basically makes it involuntarily slower to move the weight when we get higher and higher amounts of metabolic stress inside of the tissue. And with that metabolic stress, it also sucks in more fluid through osmolarity differences between the intra and extracellular environment. And thus we get this sick, gnarly pump. And for us, I'm not wearing my shirt, but the BFR Pros is #chase the pump. We chase the pump because we know that if we're doing BFR exercise, we're working really hard, we're giving our body the necessary stimulus in order to promote that adaptation. But at the end of the day, I can make the argument, even with aerobic exercise, because we see hypertrophy with aerobic exercise, I can make the argument that mechanical tension is still the driver of those benefits. BFR just accelerates that process and lowers the floor for an effective stimulus. So here are just me doing a couple of BFR exercises. This is, typically the cuff is applied to the proximal most part of the arm or the leg, and exercise is performed 4 sets, typically 30 reps followed by 3 sets of 15. You can see here as I'm getting to the end of the set on the left hand side, my face is contorting in all sorts of nice ways. This is just, kind of the indication that the patient will kind of give you. I'm showing here the nasty pump, chase the pump right there on there. So you can kind of just see the differences there. But when we think of metabolic stress, right, even though it's not a mechanism per se, we should understand that heightening the metabolic stress is going to accelerate the fatigue accumulation, and B, make the exercise more uncomfortable. So how do we do that? Well, we can add more weight, or we can add the presence of BFR, right? So if you look at the left-hand chart, phosphocreatine breaks down into creatine plus ATP, and then it also creates more metabolic stress, lactate, and a decrease in pH. And you can see here on the right, both of these are the same trial. So you can just see, the different charts plotted on the Y versus the X axis. And you can see here that metabolic stress is increased with adding heavier loads or adding BFR with lower loads. Now, this here is kind of like my hammer home point about BFR with regards to metabolic stress. If you look at this chart, this is from, I think, Yasuda in 2015, and they had individuals perform 4 sets of bicep curls to volitional failure with and without BFR. And they plotted the lactate release. Now, lactate is an imperfect marker for metabolic stress, but generally accepted that higher levels of lactate is related to higher levels of metabolic stress. These look identical, right? I hope, you say, oh, I look at this and they're identical. They are identical in terms of the decay, even back to baseline, they're identical. And this is really the hammer home that BFR is doing nothing special with regards to resistance exercise. It's simply accelerating the normally occurring fatiguing processes that happen and maybe lowering the floor a little bit, although that's for adaptation, but that's another conversation entirely. Now let's pivot quickly to safety. So I gave a presentation 2 years ago at the National Strength and Conditioning Association that made the argument that if you're safe to exercise, you're probably safe to perform BFR, with an asterisk, meaning that there's a caveat, common sense applies. And I know common sense isn't so common these days, so it bears fruit to go through some of this stuff. But in general, there are 3 concerns regarding BFR, so we'll go briefly through all of these. The first is the exercise pressor reflex. The exercise pressor reflex is a reflex loop that starts at the group 3, group 4 afferents and loops up into the central nervous system. And that tells the central nervous system, hey, I need more oxygen in my limb. And so what does it do? It increases ventilation, increases heart rate, and increases blood pressure to be able to deliver oxygen-rich blood to the extremity. And this is sympathetically driven. So that's important because a lot of conditions have heightened sympathetic activity at rest, and furthering those sympathetic imbalances might lead to higher than we'd like blood pressure responses. So things that we should expect when the exercise pressor reflex is activated are higher levels of discomfort, higher levels of pain, and higher levels of rating of perceived exertion at any given repetition compared to free flow. So these are things that, yeah, we should expect. It's a normally occurring thing, but certain populations might have a little bit more propensity to exhibit higher than expected blood pressure responses. Mostly, we're talking about systolic blood pressure. Now, let's look at systolic blood pressure. Here's a hypothetical chart where it plots the systolic versus the diastolic blood pressure in a hypothetical person, right? Performing BFR exercise and not performing BFR exercise. Now, I think I want you to think to yourselves, this is a question I ask when I'm teaching, is what is in the human body with a normotensive individual, caveat, what is the peak systolic and diastolic blood pressure responses that have been recorded in man in a near max 1 rep max attempt, so a 1 to 2 rep max attempt? And so I usually open it up to the floor, and everyone like throws their numbers in, and they see, oh, this systolic at the end of set 4 over here. At the end of set 4 over here is around 200. That seems like really high. And so I say, oh, what do you think? Do you think this is high? And then I tell them what was recorded in peak systolic and diastolic blood pressure is 480 over 350. 1985, McDougall is the lead author. So you can Google that yourself. So when we're looking at blood pressure responses in normotensive individuals, for example, we should not be anywhere near concerned about the impact of BFR on them. When we're dealing with even individuals with altered sympathetic nervous system responses, maybe we should be a little bit more cautious. But again, I would argue that if they're exercising normally or exercising already, that this is not a concern. If you are concerned for whatever reason, then we can modulate the amount of exercise pressor reflex that's activated by mitigating the amount of muscle mass recruited. That means like a leg press or a leg extension instead of a leg press, or short arc quad instead of a long arc quad, things like that. Applied pressure, we can use less pressure because pressure is another variable that's going to modulate the discomfort, but it's also going to modulate the cardiovascular response. How much load we're using, go less, more, greater cardiovascular response. Applied when? BFR is typically applied continuously, meaning it's inflated before the exercise and it's immediately deflated after the last rep of the last set. You can also do intermittent BFR, where it's only inflated during the exercise, or you can do resting BFR, where it's inflated during the rest periods alone. That's even less of a hemodynamic concern than intermittent. So they're all strategies you can be able to leverage in order to mitigate that. But I would suggest that if you are concerned, you measure it appropriately. Measure blood pressure, right? Obviously, if you're doing upper body exercise, it's going to be a lot harder, but lower body exercise, measure it. Why not? That can give you a little bit of comfort understanding that. But the evidence thus far in general does not show that BFR heightens the risk of excessive blood pressure beyond high load exercise, or at least significantly beyond high load exercise. And that's why, I said, if you're able to exercise vigorously, I'm not concerned about this at all. What's cool, though, is that BFR has displayed a superior post-exercise hypotensive response that is greater than low intensity exercise, and it's sometimes exceeding even high intensity exercise, even in hypertensive patients, which again would be, oh, wow. But in reality, we're learning that being able to stimulate a vasomotor response in the or vasodilatory response in the arteries post-exercise can help with management, non-pharmacological management of blood pressure. Then we get to the next safety risk, which is blood clots. I am really not concerned about this at all. I think that this has been overdone. I think it's been adopted early, and the evidence thus far does not suggest that BFR heightens the risk of clotting. In fact, it probably either has neutral effects or slightly decreases it, given the occlusion or the restriction and then the blood flow that comes after that releases the vasodilators and antifibrolytic activity such as TPA. So here is just looking at, this is an anti-clotting mechanism that gets released by the endothelial cells post-exercise. And in this study, in this cohort, it was measured as equal. And the same, there was another recent paper that was done in cycling, and that showed not high intensity cycling, but just cycling regular, and showed the TPA levels were similar as well. So again, I'm not really concerned about that. But if you are, you can of course screen for that and be more conservative. But BFR has been implemented in a number of different at-risk populations, such as those with chronic kidney disease, cardiovascular disease, post-surgical, etc. And so really it comes down to knowing your client patient and your risk tolerance for this. And at worst, just get screened, right? And then the third, which is not on this slideshow, which is muscle damage, which is really not a super concern either, just given proper implementation. So making sure you're not going to volitional failure with your first couple sessions to allow for the intracellular environment to get upregulated, and thus then you can go, have at it, go ham. So really, those are like the safety, concerns about BFR. And we already talked about the pillars and progressions, but here, these are just general guidelines for aerobic exercise and for resistance. For aerobic exercise, this is from Patterson et al. In 2019. 2 to 3 times a week, greater than 3 weeks, or 1 to 2 times per day, greater than or less than 3 weeks. Intensity is low, less than 50% VO2 max or heart rate reserve, with a restriction time being between 5 and 20 minutes. You can do upper, lower body exercise, continuous or interval work between, again, 40 and 80% of limb occlusion pressure. Any cuff size is fine as long as you're able to determine limb occlusion pressure. Although, again, limb occlusion pressure, in my opinion, is a nice way to relativize things between studies, between participants, etc. But is it the be-all, end-all? I'm not so confident as I once was, but I think that it's a really good way to standardize the stimulus. So I'd rather it be more standardized rather than less standardized. I just don't know if it, I'm just not 100% convinced that this is need to do this in every single person on planet Earth type, type convinced. But I do think that when you first start out with BFR, it's really important to have bumpers, much like you start with bowling and you have bumpers on your, on your lanes, the same thing. With resistance exercise, the same, frequency, right? If we take the notion that BFR operates to a similar capacity as regular strength training, this should not surprise you. It is pretty obvious to me that it does that way along with the evidence, but there is some cool things that you can observe with resistance training that don't necessarily occur with normal strength training, like proximal hypertrophy. So you walk and you can get some glute hypertrophy where you normally wouldn't. Again, an overview lecture didn't really focus too much on that, but those definitely exist. Typically with BFR, you want to do no more than 2 to 4 exercises, of which each exercise is between 3 and 4 sets a piece. So generally, if people are doing more than 2 exercises for the same muscle, I'm going to question if they're working hard enough, because you should be gassed at the end of that, especially if you're doing a big, overall arc of motion. So you're getting more muscle mass involved. If you're not gassed and wanting to get that cuff off as quickly as possible, then I'm going to question if you're actually, exercising with sufficient intensity. So the repetitions typically recommended, 3 sets are 30 followed by 3 sets of 15, or multiple sets to failure with rest between 30 and 60 seconds. Between them, less is more in this, because you don't really need to do more time under occlusion to maximize the metabolic stress. We showed in one of my papers that it really doesn't make a difference in terms of the overall physiologic stimulus. And then a recent paper that I wrote up on my Patreon, which talk about it next, is it showed no benefit for extending the rest periods. So you really just want to keep it nice and brisk, maximize metabolic stress, get in, get out, boom, get done. That is it for the quick overview. You can find me on Instagram, the HPM, or our BFR account, the BFR Pros. You can send me an email, nick@the BFR Pros. And then I have a Patreon, as I mentioned before. You can just look up the BFR Pros. I have a lot of exclusive content, in-depth discussions that you're going to find nowhere else on online. I'll want to thank Ben again for the invitation to speak, and I will open it up for questions.
Awesome job. Thank you. And we've got the first one already. For patients recovering, for example, from a lower extremity non-weight bearing injury, would you have them exercise with all 4 cuffs or just the upper arms and cuff on the involved lower extremity for cardio and strength training, for involved to catch up to the uninvolved?
I would never exercise with 4 cuffs on at all, from a safety perspective, but also like a tolerance perspective. There are some cuffs out there that say you can exercise with all 4 on at the same time, like B Strong, B3 bands. I've done research on them, and I'm friends with the people that are involved in B Strong and B3 bands. And yeah, if you're using those type of cuffs, then for all means, you can use them on all 4 limbs, but they don't really work as well as single chambered cuffs, so traditional BFR cuffs. And it takes a lot more repetitions to be able to get a fatiguing stimulus with the B Strong cuffs. So you might actually need to even modify your protocols to be able to get sufficient volume to produce a benefit there. I would just keep it 2 cuffs on if you're using a regular single chamber system. And what was the last part of the question?
It looked like they said just trying to isolate to one limb versus another to keep up the involved versus the uninvolved.
I like, for example, I am very much, again, a personal trainer / strength coach that happens to be a physical therapist. So if I have a limb that I'm able to exercise vigorously, I'm going to exercise vigorously. What does that look like? Well, if my patient has an ACL reconstruction, which the patient does, I'm doing as high intensity leg extensions as I can with them on the operated side in a protected range, like 90 to 60 in the early post-surgical period. And I'm cranking away. I'm having them crank away on their opposite side leg extensions, 6 to 8 heavy reps to get a crossover effect. that is going to be the best bang for your buck. BFR is just going to be something that, you can leverage if you want from an analgesic response. Again, I didn't talk about that in the presentation, but you'll be able to do, you'll be able to get a lot of benefit there. But yeah, I'm not doing BFR on the opposite limb if they can lift heavy.
Another question, aside from protein post strength training rehab, would you encourage your patients to also consume creatine?
I mean, as I said, I'm not a nutritionist dietitian. If patients ask what I would do and they say, hey, if you're me, what would you do if you're in my shoes? And yeah, I'd take creatine. I mean, creatine is one of the most well-researched supplements on the planet, and it has minimal to no adverse responses in a multitude of different patient populations. It is the cheapest, most well-researched supplement on earth. And I would recommend it to any single person that can take it. But again, certain people are concerned, like their doctors might be concerned about kidney function, even though that's kind of been debunked a little bit. But there are individual responses that might warrant, of an investigation or a referral with a physician to get approval. So again, anything regarding nutrition and stuff, I tend to put off and kick it to someone else. But if they're going to ask me what I would do, then yeah, I would do that. And some of my patients that have asked, I ultimately always recommend creatine.
Another question, recommendations on single chamber cuffs. Are there any that stand out to you that you like best?
I think when I get asked that question, which this is an article on the Patreon, for example, it's like, what are the criteria for me to evaluate a cuff? And so for me, it's the patient population, your budget, and your tolerance for risk, right? So without getting too into the weeds, just because a cuff says that it can inflate to a particular pressure doesn't mean that it's actually keeping that pressure during exercise. This is called the interface pressure. So the set pressure is the pressure that you set, 40% of limb occlusion pressure, for example. And the interface pressure is the pressure that's actually applied to the limb that may be 40%, or it may be over, or it may be under. So just because, and this is where my area of research, it kind of lies. So if you're asking me, what cuffs are the best, the gold standard cuff, it would be the Delphi personalized tourniquet device. But that's a $5,000 product. Not many people have access to being able to purchase that. Not to mention that it's recently changed, or at least will be changing, that you need to take their course. But not many people have $5,000. I'm lucky that I have that cuff. There are other cuffs like Smart Tools, Fit cuffs that are more affordable, that do the same thing, but might, again, the risk difference, if you're standardizing according to limb occlusion pressure, regardless of the fact that if it maintains that pressure or not, I think you're covered. I think that it's, I recently have a paper that is in review right now that kind of goes through this and makes the argument that you need to have common sense with regards to implementation of BFR. So I like Fit cuffs. I like Smart Tools. Those are really the two that I recommend. And then Delphi, of course.
Another question, have you seen any benefit from BFR for structures proximal to the cuff, such as rotator cuff strengthening?
Well, that's what I talked about. Like, there is the observation of proximal hypertrophy. I think that that it is something that is like an added bonus. I don't go for proximal hypertrophy, especially in the upper extremity, because there's so many muscles that are able to impact the the exercise performance. In the lower body, though, there's really only one muscle that can contribute, and that's the glute max. So anything you're doing that is involving some degree of hip extension or hip abduction, you're probably going to get a higher glute max stimulus. And some of the research has shown that.
Looks like the last question from the group was, is anabolic intolerance a system issue or just a specific muscle that's not being used, such as quadricep post ACL surgery?
So there is it is a systemic issue, but it's largely manifested locally. So you can think about it when we have 2 days of inactivity, we start to see insulin resistance. That insulin resistance is not just localized to the muscle. That is a systemic issue. We just see that the lack of mechanical tension and stimulus that's present is producing this atrophic presentation of the limb. So I like to think about it as much what I said before. It's a mostly local but somewhat systemic presentation. And so that's why it's super important to try to get that atrophy addressed sooner rather than later.
All right, that is the last question. I will echo the responses from the chat. Absolutely fantastic presentation. You truly know your stuff and elevated the room for everybody here. I will be sending this out to all 140 registrants, and keep an eye out for the next presentation that's going to be coming in June. And of course, please reach out to Dr. Rolnick in the multiple ways that he offered. I will be sending out his contact information in that follow-up as well. So thank you guys again. Appreciate you taking your time on a Tuesday night. Nick, amazing job, and look forward to continued collaboration.
Thank you. Appreciate the invite, and have a great night, everyone. I posted in the chat the Patreon if anyone's interested. So and thanks. Have a good night.